You manage your blood pressure. You take the medication every morning. You watch the numbers. Maybe you have a monitor on your nightstand. That discipline is real, and the protection it provides is real. And it is silently making you significantly less likely to recognize the 7 biological warning signals that appear in the 24 hours before a stroke. Not because managing blood pressure is wrong, but because the confidence it creates teaches you to interpret early warning signs as medication side effects, normal fluctuations, or just a rough morning. The warning is happening inside your arterial system right now, or it will. And the explanation you will reach for is already waiting to make it invisible. The 7 signals I am going to walk you through do not look like strokes. They look like things you have already lived through and dismissed. A brief dimming of vision in one eye, a sudden stripe of numbness running down one side of your body, a moment of double vision that clears before you can decide what to do about it. Each of those events lasts between 2 and 30 minutes and then vanishes completely. That disappearance is not recovery. It is the most dangerous feature of every single one of them. And the biology behind why it disappears is exactly what makes these signals so consistently fatal to ignore. The invisible mechanism connecting all 7 warnings is called a transient ischemic attack. Most people have heard that term. What almost nobody in mainstream stroke prevention content ever explains is what is actually happening at the arterial wall during that event, and why the word transient is not reassurance, it is a countdown. When a transient ischemic attack occurs, a small clot or platelet aggregate has formed inside a blood vessel supplying part of your brain. Blood flow to that region drops below the threshold required for normal neurological function. The symptoms appear. Then the clot dissolves or breaks apart or moves downstream and gets cleared, and the symptoms vanish. The brain recovers. The symptoms leave no trace. This is what makes a transient ischemic attack functionally invisible in daily life. It looks like a bad moment that passed. Biologically, it is something entirely different. The arterial wall at the location where that clot formed has been disrupted. The endothelium, the single cell lining that normally prevents platelet adhesion and keeps blood flowing cleanly, has been activated. Platelets are now circulating in a heightened state of reactivity. The coagulation cascade has been partially triggered. The site that produced the first clot has not healed. It has been primed. Research published in The Lancet in 2007 by Peter Rothwell and colleagues at the University of Oxford tracked over 2,000 patients after a transient ischemic attack and found that 10% suffered a full ischemic stroke within 90 days. Roughly half of those within 48 hours of the initial event. Not weeks later, within 48 hours. The transient ischemic attack is not a near miss. It is a biological rehearsal for an event that, without intervention, tends to complete itself on a very short timeline. Before I walk through each warning sign, you need to understand one piece of vascular anatomy because it determines which symptom is coming from which part of the brain. Your brain receives blood through 2 primary systems. The front system, fed by the carotid arteries running up either side of your neck, supplies the regions responsible for speech, movement, and conscious sensory experience. The back system, the vertebrobasilar system, running up through the vertebrae of your spine, supplies the brainstem, the cerebellum, and the visual processing areas. The brainstem is where your body regulates heart rate, blood pressure, and breathing on automatic. A stroke there is not the same clinical event as a stroke in the frontal lobe, and the warning signs originating in the posterior system are, by documented evidence, more likely to be dismissed by patients and by emergency physicians, precisely because they are less familiar than what people associate with stroke. The first warning sign appears in one eye, not both eyes, one. This is a brief dimming, graying, or complete blacking of vision in one eye, typically lasting between 2 and 30 minutes before resolving fully. In clinical neurology, this event has a specific name, amaurosis fugax, from the Latin for fleeting blindness. The mechanism is anatomically precise. The ophthalmic artery, which supplies blood to the retina, branches directly off the internal carotid artery, the same carotid artery feeding a major portion of the anterior brain. When a platelet aggregate breaks free from a carotid atherosclerotic plaque and travels upstream, it can temporarily lodge in the ophthalmic artery before dissolving, briefly cutting off retinal circulation. The visual field dims or goes dark like a curtain descending across that one eye. Then the aggregate dissolves, circulation restores, and the curtain lifts. Minutes later, it is gone. Most people over 50 who experience amaurosis fugax dismiss it immediately. Blood pressure fluctuation, eye strain from screens, dehydration. Those are exactly the explanations a functioning brain generates when a symptom resolves with no residual effect. A study published in the journal Stroke in 2015 reviewed emergency department records across 4 major medical centers and found that the median time between a documented episode of amaurosis fugax and a full ischemic stroke in patients who did not receive immediate treatment was 22 hours. 22 hours between a gray curtain across one eye and permanent neurological damage. The carotid plaque that shed the aggregate has not resolved. It is more unstable now than it was before the first event. The second warning sign also involves vision, but operates through a completely different mechanism in a completely different arterial territory. This is sudden double vision, diplopia, without any associated eye pain. Double vision from fatigue or screen exposure typically affects overall focus and improves when you close one eye or shift your gaze. Diplopia from brainstem ischemia behaves differently. It tends to appear in a specific direction of gaze. It comes on suddenly without any prior context, and closing one eye may partially resolve it. The brainstem contains the cranial nerve nuclei that control the 6 muscles moving each eye. Coordinated gaze requires those nuclei to fire in precise synchrony. When blood flow to part of the brainstem is briefly interrupted, that synchrony fails. The eyes fall out of alignment. You see 2 of everything, often for less than 5 minutes, and then the event resolves as circulation recovers. You continue with your morning, but the vertebrobascular territory that briefly lost circulation is the same territory responsible for keeping your heart rate stable and your breathing autonomous. This warning originates in the most dangerous region. A 2019 analysis in the New England Journal of Medicine examining transient ischemic attack presentations in 412 patients found that posterior circulation symptoms, double vision, sudden dizziness, sudden difficulty coordinating movement, were dismissed at first medical contact significantly more often than anterior circulation symptoms like arm weakness or speech disturbance. The researchers found that posterior circulation transient ischemic attacks were associated with a higher 30-day stroke risk than anterior circulation events, yet consistently received less aggressive workup at initial presentation. The warning that carries higher risk is the warning most likely to be sent home. The third warning sign moves below the neck. This is a sudden numbness or tingling affecting one side of the body, the face, arm, and leg on the same side, appearing simultaneously or in close sequence. The critical distinguishing feature is strict unilaterality. Tingling affecting both hands, both feet, or symmetrically distributed areas is almost always a peripheral nerve compression, a blood sugar fluctuation, or a positional issue from how you slept. It does not require the same urgency. A stripe running down one side of the face, through the arm, and into the leg on the same side is a different category of event entirely. It reflects the brain's topographic architecture. The somatosensory cortex maps body surface regions in a predictable spatial pattern. Specific cortical areas receive sensory input from specific body regions, and those regions are organized so that the face, arm, and leg on the same side are represented by adjacent areas fed by overlapping blood supply. When a small ischemic event briefly interrupts circulation to part of the somatosensory cortex, the affected body regions report altered sensation in a stripe that follows the brain's internal map, not the anatomy of the peripheral nervous system. A herniated disc, a pinched nerve, a carpal tunnel injury. None of these produce unilateral facial, arm, and leg symptoms simultaneously. When all 3 appear on the same side at the same time, the source is intracranial. A 2012 study in neurology examining pre-stroke symptom records in hospitalized patients found that contralateral sensory change was documented in 61% of patients in the 24 hours before confirmed ischemic stroke. 6 in 10 people had a clear neurological signal. Nearly all of them reached for a benign explanation before reaching for a phone. This pattern of dismissal is not a failure of intelligence. It is the default operation of the human nervous system in the presence of a resolving symptom. When a symptom appears, disrupts normal experience, and then vanishes completely, leaving no pain, no residual weakness, no visible trace. The brain's explanatory circuitry generates a narrative almost automatically. The gray curtain becomes dehydration. The unilateral tingling becomes the angle you were sitting at. The 2-minute double vision becomes fatigue. These explanations are exactly what those symptoms would most often represent in a person without significant vascular risk. After 50, after years of blood pressure running above optimal, after the endothelial changes that accumulate through decades of metabolic stress, the calculus is different. The symptoms are identical. What they signal is not, and nobody drew that line clearly for you until now. The fourth warning sign is one that most people assume has nothing to do with the brain at all. This is a sudden confusion, not the foggy disorientation of waking from deep sleep, not the mild lightheadedness of standing up too fast, but a sharp, unprompted state in which words stop working correctly. You reach for a word you have used 10,000 times and it is not there. Or someone speaks to you and the words arrive in the right sequence and you register them, and something in the chain between hearing and understanding has temporarily uncoupled. The clinical term for this is transient aphasia when it affects language production, and transient receptive dysphasia when it affects comprehension. Both reflect brief disruption of blood flow to the language-dominant hemisphere, the left hemisphere in approximately 95% of right-handed adults. What makes this warning sign particularly dangerous is its brevity and its behavioral invisibility. Language disruptions lasting less than 5 minutes are almost never reported to a physician. A 2014 study published in Neurology by Kleindorfer and colleagues at the University of Cincinnati examined pre-stroke symptom reporting in a community-based population and found that fewer than 40% of patients who experienced a transient language disturbance in the month before their stroke had mentioned it to a physician. The most common reason cited? They felt embarrassed. They assumed they were tired or distracted. They did not want to make an appointment over something that had already resolved. The brain's language system briefly lost its blood supply. The person apologized for losing track of a conversation. The fifth warning sign involves movement, and it is the one that most closely resembles what the FAST campaign describes. But with a critical timing difference. This is sudden weakness or heaviness in the face, arm, or leg on one side of the body. In a full stroke, this weakness is persistent and worsening. In the 24-hour warning window, it appears, lasts minutes, and resolves. Your grip on a cup loosens without warning. You bite the inside of your cheek because one side of your face is briefly not tracking with the other. Your left foot drags for 2 minutes on your morning walk, and then the coordination returns completely. The symptom closes. Your brain files it under strange moment and moves on. The mechanism is anatomically mapped. The primary motor cortex runs in a strip across the top of the brain, organized so that the regions controlling the face, arm, and leg on the same side are adjacent and share overlapping blood supply from branches of the middle cerebral artery. When a brief ischemic event interrupts circulation to part of that motor strip, the affected limbs and facial muscles receive a degraded motor signal. Contralateral weakness on the opposite side from the ischemic event, is the fingerprint of a cortical motor event, not a peripheral nerve or musculoskeletal injury. A 2016 meta-analysis in the European Journal of Neurology, examining transient motor symptoms as stroke predictors, found that patients with transient unilateral motor deficits had a stroke risk in the following 7 days that was 4 times higher than the general vascular risk population. 4 times higher. 7 days. The sixth warning sign is the one most often explained away by physical activity. This is sudden dizziness, not the spinning room vertigo of benign positional vertigo, not the lightheadedness of a postural change, but an abrupt destabilization of balance and spatial orientation that appears without positional trigger and may be accompanied by difficulty walking in a straight line. The clinical distinction between benign dizziness and brainstem origin dizziness is not always obvious from the inside, but 2 features shift the calculus significantly. First, brainstem origin dizziness tends to appear suddenly while you are already stationary or already moving at a stable pace, not at the moment of a posture change. Second, when accompanied by any of the other 6 warning signs, even a brief visual flicker, even a moment of clumsiness in one hand, the posterior circulation origin becomes substantially more probable. The cerebellum and brainstem regions fed by the vertebrobasilar system integrate sensory input from the inner ear, the eyes, and the position sensors in your muscles and joints into the spatial map your nervous system uses to keep you upright and moving accurately. When blood flow to these regions is briefly compromised, that integration breaks down. The floor feels unreliable. You reach for a wall, you sit down, and then the feeling passes and you attribute it to dehydration or overexertion. A study published in Stroke in 2018 by Kim and colleagues at Seoul National University Hospital, analyzing pre-stroke dizziness presentations, found that isolated dizziness, as the only presenting symptom, was associated with posterior circulation infarct in approximately 11% of emergency department patients, a rate substantially higher than the prior clinical literature had estimated, suggesting significant underdiagnosis of vertebrobasilar transient ischemic attack presenting primarily as dizziness. The seventh warning sign carries the most specific and well-documented stroke risk of all seven. This is a sudden, severe headache that is genuinely unlike any headache you have experienced before. Not a tension headache slightly worse than usual, not a sinus headache that has shifted position, but a headache with a qualitatively different character that arrives suddenly and reaches peak intensity within seconds to a few minutes. The benchmark in clinical neurology is patient-reported difference in quality, not just intensity. People who experience this headache and go on to have a stroke consistently describe it in retrospect as unlike anything previous. In the presence of any vascular risk factors, any prior cardiovascular history, or any of the other 6 warning signs in the same 24-hour window, this symptom is a neurological emergency without exception. Let me tell you something that took a long time to land personally, because I spent years watching someone I love dismiss exactly these warning signs for exactly the reasons I have described. My father had 2 episodes in the week before his stroke that we later reconstructed from conversations he had with my mother. One was brief vision dimming in one eye, which he attributed to his new blood pressure medication. One was a moment of word confusion on a phone call with a colleague, which he dismissed as distraction. He did not call his doctor. He did not go to the emergency room. His blood pressure was being managed well. He was doing everything right. What he did not have, and what I have been working to make sure other people have those, was a clear map of the biology happening in those 7 days and those 24 hours. Understanding the mechanism is not the same as experiencing it, but for the person reading the map before the event, it changes the outcome. Here is where the mainstream medical system has consistently failed the population most at risk. The FAST campaign, Face, Arms, Speech, Time, was developed as an emergency response tool. It was designed to get people to call 911 during a stroke, not to trigger action in the warning period before one. That is not a design flaw. It is a deliberate scope decision that made sense for the emergency medicine context it was built for. The downstream effect, however, is a cultural framework that associates the word stroke with an acute dramatic event, the collapse, the facial drooping, the slurred speech, and leaves an absence of public education about the pre-stroke warning window that the research has documented in detail for nearly 2 decades. The clinical tools to act on this gap already exist. The ABCD2 scoring system, validated in The Lancet in 2007, was specifically designed to risk stratify transient ischemic attack patients by their likelihood of progressing to a full stroke within 48 hours. Rothwell's Oxford TIA clinic demonstrated that immediate evaluation and treatment of transient ischemic attack patients, same-day workup and antiplatelet therapy initiated within hours, reduced the subsequent 90-day stroke rate by approximately 80% compared to standard delayed outpatient evaluation. 80% reduction. The intervention is not exotic. It is early treatment of a recognized event. The barrier is recognition, which requires the person experiencing the symptoms to know what they represent before they resolve and get explained away. The information to close that gap has been sitting in peer-reviewed neurology literature for nearly 2 decades. It has not entered the mainstream public health conversation in any systematic way. There is no pharmaceutical product to sell and no procedure to bill for telling someone that a 2-minute visual blackout in one eye is a neurological emergency. The FAST campaign gets funded and distributed. The pre-stroke warning education does not. You are watching this because you found that gap yourself. The next chapter is where this knowledge becomes actionable. The 7 warning signs I have described are not equally distributed across the adult population. They cluster in a specific demographic with a specific vascular and metabolic profile, and if you are over 50 with any history of elevated blood pressure, elevated fasting glucose, elevated LDL cholesterol, or prior atrial fibrillation, you are inside that cluster. Data from the American Stroke Association's National Stroke Registry shows that the majority of first ischemic strokes occur in adults over 65. But the transient ischemic attack events that precede those strokes are frequently documented in the decade prior, in people who are 55, 52, 48. The warning window is often happening in your 50s. The stroke arrives later. Understanding the biology in this window is not early prevention. It is the intervention the research shows is most effective. Now, I want to give you something you can use the next time any of the 7 signals appears. This is the active protocol. 3 steps, each with a specific number attached, that translate the biology I have described into behavior you can execute while a symptom is still happening, or in the minutes immediately after it resolves. The A stands for acknowledge. When any of the 7 warning signals appears, a gray curtain in one eye, a stripe of numbness down one side, a sudden word that will not come, a 2-minute arm weakness, the first and most critical step is to acknowledge it as a potential transient ischemic attack rather than reaching immediately for a benign explanation. This sounds deceptively simple, but the neuroscience behind why it is difficult makes it worth being explicit. The brain's default mode network generates explanatory narratives for ambiguous stimuli automatically, in real time below the level of deliberate thought. The explanation arrives before the analysis. By the time you are consciously thinking about the symptom, the explanation, eye strain, dehydration, sleeping position, is already competing with accurate recognition. The way to interrupt this default is behavioral. Name the symptom out loud or write it down immediately using the words potential TIA event. Naming it verbally or in writing activates the prefrontal cortex's deliberate evaluation pathway and creates a record that cannot be revised by the rationalization that arrives moments later as the symptom begins to resolve. This step takes less than 30 seconds. It is the step that everything else depends on. The C stands for clock it. Immediately after acknowledging the symptom, note 3 specific data points: the exact time the symptom began, the exact duration once it resolves, and which specific symptom it was, and which side of the body it affected. These data points are not administrative record keeping. They are the clinical inputs that determine how the emergency department will treat you and how urgently. The ABCD2 scoring system, the validated risk stratification tool used by emergency neurologists to determine who gets immediate inpatient workup versus outpatient follow-up, requires symptom duration as a primary input. Symptoms lasting more than 60 minutes carry dramatically higher subsequent stroke risk than symptoms lasting under 10 minutes. A score of 4 or higher on the ABCD2 scale is associated with an 8% stroke risk within 2 days and requires immediate inpatient evaluation. Duration is the variable that moves the score. Arriving at an emergency department and saying, "I had some numbness on my left side, I think it lasted a while," produces a different clinical response than saying left-sided face, arm, and leg numbness, onset at 7:42 in the morning, duration approximately 11 minutes, fully resolved. The second report triggers a stroke protocol. The first may trigger a blood pressure check and a follow-up appointment. The difference is the data you recorded in the 2 minutes after the symptom resolved. The T stands for transport. Within 90 minutes of symptom onset, not after calling your primary care office, not after waiting to see if a second symptom appears, present to an emergency department with stroke protocol capability. 90 minutes reflects the documented time sensitivity of the interventions that reduce subsequent stroke risk. Antiplatelet therapy, initiated within 24 hours of a transient ischemic attack, is associated with a 70 to 80% reduction in subsequent stroke risk, according to pooled analysis from multiple randomized controlled trials. Same-day brain imaging, CT angiography or MRI with diffusion weighting, identifies the source of the TIA event, whether it is a carotid plaque, a small vessel disease pattern, or a cardiac source, and that identification changes the treatment. The carotid plaque producing emboli may need surgical intervention within days. A cardiac source may require anticoagulation rather than antiplatelet therapy. A small vessel pattern may prompt a blood pressure target adjustment. None of these treatments can begin without the imaging, and the imaging cannot happen if you are at home waiting to see whether the symptom returns. There is one mistake that invalidates everything in this protocol, and it is the most common structural error in the population that actually takes stroke warning signs seriously. The error is waiting for the symptom to persist before deciding to act. The reasoning feels logical. If the symptom is already gone, maybe it was not serious. If it comes back, I will go to the emergency room then. This is the most dangerous application of normal human decision-making to an abnormal biological situation because the entire definition of a transient ischemic attack is resolution. Every single one of the 7 warning signs I described in this video is characterized by the fact that it goes away. A symptom that persists is no longer a transient ischemic attack, and it is a stroke already in progress. Setting the decision threshold at wait and see if this resolves means you will successfully wait out every warning signal the arterial system generates, because resolution is guaranteed. The decision to act must be triggered by onset, not by persistence. The moment the symptom appears and you name it, the clock is running. After 50, 3 variables make the ACTI protocol more urgent than it was at 35, and they compound each other. Endothelial function declines with age, reducing the arterial wall's natural clot-clearing capacity. Metabolic changes mean the platelet response to endothelial disruption tends to be larger and more sustained than it was a decade earlier. And atherosclerotic plaques have had decades more time to accumulate the unstable lipid-rich cores, most likely to rupture and shed emboli. These 3 factors do not make stroke inevitable. They make the 7 warning signs, when they appear, more predictive of an impending event and more time-sensitive than the published general population statistics suggest. Because most of those statistics were generated in populations with wider age distributions. For you over 50, the urgency at the top end is higher than the average implies. One piece the mainstream conversation consistently leaves out. The emergency department visit after a transient ischemic attack has a defined workup that you are entitled to request by name, if it is not being initiated automatically. The TIA workup includes brain imaging with CT or MRI, carotid ultrasound or CT angiography of the neck vessels, a cardiac monitoring period, typically at least 24 hours, to detect paroxysmal atrial fibrillation, and a fasting lipid and glucose panel. If you arrive at an emergency department, your symptoms have resolved, and the clinical team is preparing to discharge you with a follow-up appointment and no imaging, you have the right to say, I would like the TIA workup completed before discharge, including carotid imaging and cardiac monitoring. That is not an unreasonable demand. That is the standard of care established by the American Heart Association and the American Stroke Association in their joint guidelines. Knowing it exists is the difference between a discharge that restarts the countdown and a workup that identifies the source and stops it. If you're going to use the ACT protocol starting this week, comment the word ACT below. Not as a commitment pledge, as a signal that you have the mechanism, not just the acronym. I read every comment, and I am tracking how many people in this community are moving from information to behavior, because that gap is exactly where the preventable events happen. If this is the kind of content you want, mechanisms not motivation, every claim sourced, no simplifications that cost you something you cannot recover, subscribe to this channel. 1 video a week, built the same way every time. The next video goes 1 layer deeper. What happens inside the emergency department during a TIA workup, which specific questions to ask, and the 1 imaging result that changes the treatment plan completely. That information does not appear in any public health campaign.